Good afternoon, everyone. Thank you for joining today's webinar presented by Guidehouse on managing your revenue cycle's response to COVID-19. Please note that all lines have been placed on mute to prevent any background noise. If you would like to ask a question, you may do so via the Q&A feature in your GoToWebinar dashboard, or you may use the raise your hand feature to ask your question via telephone. Once our speakers have concluded, we will compile the Q&A roster. Please also note that the call is being recorded and all materials will be made available and sent out as soon as possible. I will now turn the call over to Mr. Tim Kinney. Go ahead, Tim.
Great, thank you, Rebecca. And you can go one slide forward. Perfect. Thank you, everybody, for joining today. I really, again, appreciate you taking time out of your busy day to join us. I hope first and foremost that everybody is safe and healthy as we progress through COVID-19. Just one quick reminder, as Rebecca stated, we will send all the material after this webinar, and we will also have a link on our website where we're going to house past information and then all of the Guidehouse information related to COVID-19 as well. So real quick, I am joined by a great cast today, some great colleagues with me in Guidehouse. Quick introduction, myself, Tim Kinney. I'm a partner and I lead our revenue cycle business unit, joined by Ian Stewart. He's a managing director in our revenue cycle division as well. He is really on the front lines, day-to-day nuts and bolts, and is going to share some of his lessons learned today with us. Subra Zapata, part of our healthcare technology group and leads that division. Former administrator and CIO, so has some really good perspective on, telehealth and what has changed so drastically with COVID-19. And then I'm also joined by Sue, Tess, Michelle, and Jeannie, our HIM team, deep expertise in the coding and billing stipulations that we'll get into today. So really excited to be part of this group. A couple other things I would just note as we get into it. This is our second webinar related to COVID-19. Our intent is to provide tactical information to the group on the phone. So this is information that you guys can hopefully use, day to day to manage the business. We will also let you know, as you guys that are living in RevCycle, you understand this better than anyone. The information is updated daily, if not hourly, and we're trying our best to stay on top of it, and we'll make sure that, again, we're doing our part in communicating this out to the group and following up at the end with any specific questions. Today, we're honing our conversation in on telehealth as it relates to revenue cycle. It's been very interesting. We've heard a lot of feedback over the past week from surveying our client base. Most organizations had a plan. COVID-19 has accelerated that plan. And what we've seen in the impact in RevCycle is there's obviously coding and billing impact, but with our payers taking some of the restrictions and stipulations off of how we operate in a telehealth world, it's really opened the door for an accelerated implementation. So we wanted to talk about that today. We do understand it's larger than revenue cycle. So again, we've assembled a good team, but if there's other questions, we're happy to get back to you guys. At the end, we'll do a Q&A. So if you guys have questions, feel free to submit them. Nothing too big, nothing too small. If we don't have the answer for you, similar for those that were on last, the answer and get back to you guys as well. So with that said, I'm going to turn it over to Subra. He's going to give us a quick lay of the land with telehealth and what has changed in this new environment. Subra?
All right, thank you, Tim. Good afternoon, everyone. Next slide, please. We thought a good place to start would be what changed. As you know, telehealth as a concept has existed for a long time, but with COVID-19 and the relaxation of regulations, the majority of services delivered to Medicare beneficiaries via telehealth are now reimbursable at full rates. That's a big change. As you know, the biggest barrier for progress on telehealth has been reimbursement. They've also relaxed many practice restrictions as well. And given that fact and the fact that reimbursement was a barrier in the past, a lot of organizations either have not invested or progressed or matured their telehealth platform, or if they have it in a smaller scale. Technology has evolved greatly, wherein our patients and consumers can use mobile devices, desktops, etc., for video visits. EMR systems through their patient portals have made access convenient for patients. There are a number of third-party vendors as well, like Teladoc, Amwell, to name a couple, that offer platforms that complement or even substitute any platforms you might have and extend capabilities that and make it a true 24/7 operation. So our viewpoint is that many of these restrictions that have been lifted will remain so post-COVID. They might roll back some, but many of them will remain so. And therefore, we believe incorporating telehealth into your strategy to drive access and growth is a must. And you know, from as a platform to drive lower cost of care delivery, you know, responding to consumer demands of on-demand access for services, to support your value-based care, population health efforts, etc. And it doesn't hurt that that there are a number of grants now that are also available. My team will get into some of that as we get into the detail. And it's possible that you could take advantage of these grants for any costs that you would incur in standing up these programs. So we believe the time to act is now, and take advantage of this opportunity. Next slide. We are going to get more, as Tim said, very tactical in terms of these changes in regulations. Just to give you a high-level overview, you know, Medicare will reimburse over 80 additional telehealth services. The Office of Civil Rights is offering penalty waivers for HIPAA violations, etc. ASCs may contract with local health systems to provide hospital services during this period, and so on and so forth. And again, we're going to get into each of these and specifically coding, billing, and revenues type of things in more detail in the upcoming slides. Next slide, please. So as we take this call to action, there is a short-term view of things and a long-term view of things. Today, you know, as we're going through this pandemic, maintaining current volumes and through a telehealth platform is something many clients are leveraging at this point. You know, as I said, take advantage of the full reimbursement period to stand up this platform and explore the grants. And operationalizing the telehealth platform is really the key to efficiently leveraging these capabilities. We think that's the biggest lift for organizations. And then what I mean by operationalizing is, you know, making sure that the credentialing and licensing requirements are addressed, figure out the intake and scheduling, shift in workflow and training, the EMR build that's involved, marketing to your consumers / patients in terms of the services that are available through this platform, initiating patients, educating them on the technology you're going to use, and any interoperability of technology that's required for documentation and follow-up purposes. Take care of all of those things as we build up this platform in the next 30 to 60 days. Of course, address the physician compensation, contract adjustments, productivity related measures, etc. And key to all of this is privacy and security as well. As you go more and more virtual, you want to make sure that the cybersecurity defenses that you have put in place are going to stand the test of this increased volume and exposure of data into the public domain. And that's what we believe needs to be addressed in the next 30 to 60 days. And as you take a longer term outlook as we come out of this pandemic, you know, even if some of the regulations are rolled back, you would have taken advantage of setting up a robust platform, have a workforce that's trained in leveraging this, processes and procedures that are aligned in clinical workflow that is built in. So you can take advantage of this platform longer term as part of an access and growth strategy. So with that, I will ask my colleague Ian to kind of give you some proof points on what I just said with some real live example of what he's going through as we speak. Ian?
Hey, thank you, Subra. Glad to be here. Could we go to the next slide? So today last week I talked a little bit about kind of billing, this week access scheduling, and how in a real life scenario, you know, I'll tell you, you know, 3 weeks ago, we started off with, business continuity planning, what if scenarios, how will our teams work on site, business as usual, and just what are we going to do in a matter of such a short period of time. We've moved quickly to telehealth, phone health, remote work, get as many people out of the site as possible from a safety perspective, but also from pure reality. So I'm going to talk a little bit about the business aspect of things that we've had to think through. But to put it in perspective, we have had a tenfold increase in our telehealth offerings and visits. We used to do about a couple hundred a month, and now we're on pace for about 3,500 in the month of April for a 2-hospital system that I'm managing with an operational team. So there has been a tremendous increase in this, and so some of the things that I've been thinking about, I'll walk through. So how do we intake remotely? How do we prepare for significant volume of telehealth and phone interactions? Access staff are hard to replace. You can't train them fast enough. And the front line had started to become sick. We lost about 15% of our people in the ED and the other sites of care within the facilities. And we weren't able to get folks to help them. And so I pivoted very quickly to moving as many of the staff off site to home as possible and getting the capability set up during this COVID period. It spawned a number of questions: technology, system setup, how do you do it remotely? How do you capture forms and IDs, insurance cards? I know they've relaxed HIPAA, but you want to keep HIPAA and safety of data top of mind as we've done that. So as continuing to move that technology to their homes, the different types of visits, e-visits, phone, tele, how do you do pre-reg, pre-cert, billing expectations, everything changed overnight. The new visit types that flow into the EMR and billing systems have kind of created this concept of a super documentation form that includes time and type of service and location and where the activity was done, the type of patient it was, so that we can get any and all things that the insurance companies may require downstream for this new reality. How do we schedule the ED from home so that we don't have to use PPE and we can use tele-remote check-in systems or phones or other things? So a tremendous amount of new activity in the last 21 days has really spawned a number of conversations around how to do it. The next slide, please. So the other thing that's been significant on my mind is managing load needs. For a lot of systems, the volume hasn't kicked in yet. You reduced all your outpatient volume, your surgery volume, your EDs are way down, your inpatient hasn't ticked up. And so you're in this bifurcated world where staffing needs to be looked at from furlough. Staffing needs to be looked at from just flex management. And so I took a lot of those staff and I utilized them in different areas. Self-pay, looking at all of our conversions, making sure that we're applying for Medicaid and Mang. I've put them on denials for eligibility and other small balance denied AR because I want to keep them engaged and not send them home. But then it gets to how do you plan and prepare for the increase once tele and phone and remote visits come online. We've had a tenfold increase. If that continues, how do we do that work? Where do we do it? And is my team prepared for the long haul as we think this COVID work from home situation will go for a number of weeks, probably to June, July, and going forward, this new reality probably is much more apt to stick than it has in the past. The other thing is sites close. There's been a few hospitals that have just closed down because they can't make it financially. There's been labs and outpatient system locations that weren't ours that closed down. And those patients are starting to present in lab and EDs and to our primaries for visits. So we've had to put together much more robust analytics around daily tracking metrics to flex up and down in real time. So on one side, we're being asked to flex down because we don't have the revenue to support everybody. And on the other side, we really need to be able to flex up as all of these other activities come into play here over the next 4 to 8 weeks. And my last point is what we know today will last tomorrow, and so stay open to change and, you know, continue to be adaptable to this current situation. So those are my slides.
Hey,
I'm gonna now...
Rebecca, can you hear us?
Yes, I can hear you.
Yep, Sue is next. She's gonna give some tactical updates on coding.
Next slide, please. So thankfully, CMS has recognized that patients need a lot of different services during this PHE time period. And they've really gone about and made some very generous changes to a bunch of different modalities that traditionally would not be covered in a telehealth setting, but now are. So I think the big ones on here, you know, obviously they're all important, but PT is a big one for this, home visits, ER visits. So we're going to take a little bit of time and go through the different areas and provide you some maybe I'm sorry? Some documentation and coding tips. Next slide, please. So when you're going about billing for your telehealth services, you have to provide some unique information. Now, depending on where the provider is actually performing the service, that will actually be your location for billing purposes. You do not have to enroll with Medicare with all the different locations. Any discrepancies in the address will not cause any payment issues. And you are to use the place of service that you would have used if it had been a normal visit. So if you're in a provider-based clinic, you would use an outpatient place of service. If you're in a physician office, you would use 11 and so on. Institutional claims, you're still going to be able to bill the originating facility fee under the Q3014 and use the GT modifier. Next slide, please. And Tess, do you want to take it from here on this one?
Sure, thanks, Sue. Along with some of the sweeping changes with the exceptions in the 1135 waiver, there were also some additions to the ICD-10 coding and some new CPT and HCPCS coding. So effective now, as of April 1, we have the ICD-10 diagnosis code, the U07.1, and that's for confirmed COVID diagnoses. There's also the lab testing codes, your CPT 87635, which is the testing code for COVID virus. And one thing to keep in mind, we might have mentioned this on the previous webinar, is that when it comes to coding the CPT code, the 87635, if you are taking multiple specimens from the same patient on the same day, for instance, if you're doing a nasal swab or an oropharyngeal swab, you're going to report that CPT code 2 times. You have the 87635 once, and then you report it again and apply the 59 modifier. And this is effective for tests that have been performed since the 13th of March. And then we have the HCPCS codes, your U001 and your U002. And basically, these were introduced specifically to allow laboratories, providers and laboratories conducting the COVID tests to be able to bill for those tests using the specific HCPCS code versus an unspecified code. And this just allows for better tracking of the public health response. I mean, this is all about data, and when they're trying to figure out how this, this virus is manifesting, who it's manifesting in, having this diagnosis specificity is going to help gather that geographic data. And anyone who has any coding savvy at all knows that you always want diagnosis specificity anyway, right? Difference with those two codes, your U001 is for healthcare providers and labs using the coronavirus real-time diagnostic panel. And the U002 is by any technique, multiple types or subtypes, or a non-CDC lab. So that is the difference in those two codes. And next slide. So first off, there's been, I think, not only in coding and billing, but there's been massive changes everywhere in regards to healthcare's response to COVID virus. Sue had mentioned at her very first slide had covered some of the expanded telehealth codes, whether ED visits, your OB services are now included, radiation and hospital discharges. So to go into specific detail on all of those services would really would do my head in, but I think we could be here for several hours. But suffice it to say, with the expanded services, those expanded codes, they're still allowed providers can waive the cost sharing component, so they can reduce or waive co-payments for all of these telehealth services that have been added, okay? Furthermore, there have been some changes in regard to your virtual check-ins, which is those G codes, the 2012 and G2010, and your e-visits. And I think the biggest change there is that those were previously, or under normal circumstances, you were using virtual check-ins and e-visits, or an established patient relationship had to be in place. So new patient services were not billable. You'd get denied due to the public health emergency, and for the duration of it, I should say. These services, your virtual check-ins and e-visits, have been expanded to include those new patients as well. That I think is kind of, I think that will be taken advantage of. There were some smaller changes in remote patient monitoring. So basically, if you're just monitoring one condition, it is now allowable. And then another pretty significant change was a relaxation of the frequency limitations for the inpatient, the subsequent rounding visits, your skilled nursing visits, and critical care consults. So previously, or under normal circumstances, you had some frequency limitations. Those have been lifted as well. And another requirement, a lot of our services, whether it's in the outpatient, inpatient, there are supervision guidelines, and those have been expanded where direct supervision can now be provided remotely, but it has to be a real-time audio visual type technology. So this is really, at a glance, it's really just dipping your toe in the water to some of the overwhelming changes that have taken place in the coding world and documentation world. So I'm sure if some of this is going to affect some people on the phone in more drastically than others, we are here to help you if you have specific questions. We'll definitely dig down deeper to help you out specifically, but I think it would just be way too long to go into these in depth. Next slide. All right. So you hear telehealth bantered around a bit, and I think everyone, there's telemedicine, telehealth, your virtual check-ins, your e-visits. But basically, if you just look at it in two ways, are you sitting in front of that patient face-to-face or not? And what we're talking about here is all of those services that we're providing without that direct face-to-face patient-provider contact. Some of these requirements that you'll see in the telehealth services, this is where a lot of those CPT codes that you're seeing listed in the first little slide here, your 99201s through 99205s, a lot of these codes, a lot of these services, this is where your expansion has been found. So there is a wider range of CPT codes that can now be included as payable, reimbursable telehealth services. And when you're thinking of that, some of the key takeaways now in this expanded world is, again, we had that cost sharing flexibility where the co-pays can be waived. And the HHS has said that they are not going to be performing audits to ensure the prior relationship existed. So again, this is just a very detailed slide. Read it at your leisure. And the next slide.
Thanks, Tess. I'll take this one. So we know how to bill for it now. And now the question that we're getting from a lot of our clients is what do the physicians have to document? What needs to go in the note in this period of this pandemic? And CMS surprisingly has been the most relaxed with their guidelines. Usually they're the more stringent ones and we have more flexibility with commercial insurance, but currently that is not what we are seeing. Now, again, all advice is based on CMS guidelines. You really need to follow up with your payers. I believe we're going to add some carrier determinations into the appendix to ship out to you guys to let you know what we know, how the bigger insurance companies are handling this during this time period. And again, these decisions that are being made are really for the period of the PHE. When that ends, who knows what will come next, but this is just for this time period. So the first thing that we want to make sure that we document, there are no CMS guidelines other than you need to document that you're providing a telehealth service and who you're doing it and how it's being provided. HEMA provides on telehealth and suggested that the location of the patient, the provider, and the names of any other persons participating in telehealth are documented. So I think we're all good with that because we need to do that to make sure everyone understands that it is telehealth. But the bigger focus in this is the actual documentation of the medical record. So CMS is focusing on medical decision-making and not holding physicians and providers to the traditional E&M guidelines. What that means is for the focus is on the medical decision making. Really, they want to pay you based on what is wrong with your patient and what you are doing for them. They are relaxing and removing the requirements for the history and or physical exam components. That does not mean they don't have to do one. They still need to document as appropriate in each of those categories as it relates to that patient encounter. Sometimes when physicians hear they don't have to do something, they don't do it. So that's not what we're saying. You still need to document to support your medical necessity of the visit as well. And again, this is based on CMS guidelines. The bigger insurances, it looks like, have not yet relaxed this. The other way physicians can meet it is through the documented time. And all the CPT codes have approximate times related to them. We've put the link down there below, and that should give you all of them for all the different categories. But this really includes only the time of the reporting practitioner for that visit on that calendar day. So if somebody is prepping things for him, we can't count for that time. This is strictly the time that the provider has spent either preparing for that encounter, having that encounter, or wrapping that encounter up. That's what we're looking for physician time. And it needs to be documented. And they're not going to use an appointment schedule to determine the length of time. Can't say a long time. CMS has relaxed a lot of requirements, but you actually have to document the time that you spend. So again, we want to make sure that we're focusing on your payer so that you know whose rules apply to what, because at some point documentation may be looked at. We don't know what they're going to do. So with that, I'm going to wrap this up. And Tim?
Yeah, thank you, Sue, and thank you, Tess, for the detailed information. At this time, we'll go ahead and open it up for questions. I did want to let you guys know, too, I apologize if you're having any audio issues. We know the platform is experiencing high traffic, so we'll do our best to get through it. But we'll open it up to this questions at this time, so feel free to submit them if you have them. Rebecca, do we have any in yet?
We do. The first one is when it comes to billing insurances for telehealth visits, since the insurance are relaxing the requirements, what do you suggest to allow them to appreciate the new billing requirements and get the invoices billed?
Hey, thanks. This is Ian Stewart. I'll take that one. You know, I had said last week that I think one of the stone things that really needs to be done from a strategic perspective is that your managed care team in partnership with revenue cycle and operations really needs to build a grid by payer, by type of service, by location of service, and get their real expectations for how codes, how they anticipate things need to be built, from a place of service to a CPT code to a type of code, and for a very specific delineation around what they expect and how they'll expect it to be done. Verify that they have set their system up to take those codes in, and then release those codes by payer from your editing system as you're able to try to get your cash flow to stay very solid. So that will not change anytime soon. I've had a few payers even backtrack on what they told us initially, and so having those things, you know, every day, every other day, a few times a week, whatever you guys can muster from your payer and revenue cycle partnership, that's absolutely critical at this time.
Thank you. Our next question, our concern is that our PT PMR services are under the facility and Medicare has said it's not for UB facility billing. Are you billing on $1,500 for these services, the therapist NPI?
So, would you guys know that one?
Yeah, could you repeat it? I broke up. I couldn't quite hear it.
That's all right. Our concern is that our PT PMR services are under the facility and Medicare has said it's not for UB facility billing. Are you billing on $1,500 for these services?
I can take that. These are normally provider-based services that would go on a 1,500.
Okay, thank you. The next question, is both audio and video required to bill e-visits, online patient portal?
No, they are not. That was the e-visits you said, correct?
Yes.
Yes.
Our next question, can hospitals bill e-visits on a UB04 for the therapy services?
We're working.
I am not.
Yeah,
I was going to say I could do a little more research on that from the coding side.
Yeah, we are doing some. Other payers are allowing that, and others are questioning it. So back to my kind of status of payer by payer.
All right, the next question, can you please review Medicare's rules in regards to new patients? Which codes will be covered for new patients?
So for the new patients, for the telehealth, we're still looking for the telehealth visits. You're still looking at your normal E&M services. So your new patient codes from 99201 through 99205 for telehealth in the office. For your commercials, you may have consults, which could be for a new patient. For the telehealth portion that that we were talking about, the GO 102, those codes are for both new and established.
All right, sounds
Was
good.
there any other category?
That's all there was.
All right, thank you.
This question is for Ian. From a claim submission standpoint, are claims going to be considered back to January?
I'm going to read into that is that if there were COVID cases that went back to January, would they be considered under this new process? That's my understanding, is that they are backdating, at least via Medicare's guidance from what I've understood as of today, and that may change. Some of the payers, on the other hand, have not allowed us to backdate that far. So for the most part, I believe it to be the case, but I'd have to counsel to to double check and see what specific insurance companies will allow.
Thank you, Ian. Next question, for provider-based billing, may providers bill a technical fee for telehealth services performed at the provider's practice location?
Well, the facility will bill the originating site code. The provider would be billed for his services.
And if the provider is employed or is part of that, many of the payers, regardless of where the service is done, is allowing you to bill just as you would have in your facility, your office for that service during the COVID period.
Thank you. The next question, what have you seen to date in terms of reimbursement from commercial payers? Are they following Medicare guidelines?
I just released claims yesterday on the first set of activity, and so I don't have any. It's too early to tell exactly how they'll reimburse based on what they've told us. So I think in another 2, 3, 4 weeks we could probably have some real life data to answer that better than hypothetical at this point.
Thanks. I think the rest of the questions are very, very technical, and I think we can pass those on to our panelists if that's what we want to do to answer directly. How do you want to handle?
No, I think that sounds like that. So we will, again, make sure we get the material out. This deck will point you, the audience, to our website for additional material, and then we'll do some detailed diligence on the very technical ones and make sure we get back to everybody in a follow-up as well. But want to thank you again. We appreciate your time. We appreciate everyone that's working to combat COVID-19. Those revenue cycle professionals that are frontline, you're especially appreciated. And we will keep the group posted. Our intent is to do this, every week or every other week to make sure that we're staying front and center with information. And again, thank you for your time. Stay safe and stay healthy.
Thank you for joining today's call. Again, as a reminder, today's call was recorded. Please be on the lookout for a link to the recording in your inbox. You may now disconnect. Thanks, everyone.